Thank you for taking the time to watch. This bill proposes specific solutions that address the core problems we face in healthcare spending and overall patient care. Let's look at the core problems. Medicaid spending is taking up an increasing portion of overall state spending, meaning that other things the state funds, such as education, infrastructure, public safety, all are under pressure from Medicaid spending. This has resulted in lower overall spending as a percentage of the state budget in education and human services. Even under the best case scenario, the Medicaid expansion population will cost the state significant money in the future. And the cost per person for Medicaid spending has recently gone up when you'd think it would go down because of the numbers of able-bodied lower-cost adults joining the rolls. In the past, the solution has been to simply mandate that we spend less on Medicaid, but that has only resulted in lower reimbursement rates for Medicaid, making it harder to find a doctor and more likely for Medicaid patients to simply go to the ER, which is much more expensive. The goals of this bill are to lower healthcare spending, improve patient health, and use the savings below what we currently spend on Medicaid to help needy populations. There are a host of ways to lower spending and improve patient health. This slide shows an overview of the entire bill and all of its major components and can be divided by reduced Medicaid spending, lower overall healthcare costs, and how we use our savings. Several of the core problems with healthcare can be best demonstrated by looking at a hypothetical doctor-patient interaction where the patient doesn't have anything really wrong with them but thinks that something seriously might be wrong. The patient then wants an expensive scan and doesn't care about what it costs because there's nothing out of pocket from the patient, no copays, no deductibles. Not caring what something costs is a problem in the entire healthcare system, but particularly in Medicaid, it's a problem because there's not a way to charge a deductible or a copay. The first reform in this bill is modeled on a very successful Indiana program that was piloted in 2007, where Medicaid enrollees were charged a yearly premium of $99, and that money was put into an account that could be accessed with a debit card and matched with $1,000 of state money. The money in their account would then be able to be used for the next yearly premium charge so that the participants cared about keeping money in their account. It also mandated that they get preventative care or the state money didn't roll over to the following year, and they found significant increases in preventative care. We added a couple of additional reforms so that money could be added into the account and be used for non-covered services based on successful health outcomes such as losing weight, lowering your blood pressure, that type of thing. Also, in the Indiana plan, they were able to pay Medicare reimbursement rates instead of Medicaid rates, which are much higher, which improved access to care. Another additional component that we added in this bill that wasn't in the Indiana plan was that the money that's in the account, if a patient comes out of Medicaid because they increase their income, the money gets put into a bridge account, which is frozen and can be used for out-of-pocket health care costs. So there's not a hesitation to come up and out of Medicaid. Based on the results achieved by Indiana, Ohio should save $500 million if it implemented this program. Throughout this presentation, we'll keep a running total of Medicaid and overall healthcare savings and improved health outcomes. Back to our hypothetical interaction. Say we implement the Healthy Ohio plan and the Medicaid enrollee is carrying what the costs are, but unfortunately the problem for all of us is we don't know how much we're spending when we get healthcare services. The bill offers 3 reforms to increase price transparency. The first is that before any non-emergency service, the provider must give a written estimate to the patient as to what the overall costs are going to be, how much the insurance or how much Medicaid is going to pay for that service, and then what the out-of-pocket costs are going to be. The second reform is that we would allow advertising of healthcare costs, which sometimes are prohibited in private insurance contracts. Finally, we will make sure that all insurance companies that are offering policies on the exchange publish all of their out-of-pocket costs for the top 20% of the services that they insure, so that somebody who's shopping on the exchange for a healthcare policy will know how much those services are going to cost them. There's not a lot of data on how much price transparency could save us in overall costs, but in a couple of studies for some non-emergency services, having the information on a website so that patients could shop before using services resulted in over 10% savings. It's also useful to look at the difference between inflation overall in healthcare and inflation for cosmetic procedures, which typically are advertised so that there's cost consciousness and are also out of pocket, so there's skin in the game, and you can see the stark difference between the two. Were we to implement these reforms, even being extremely conservative and saying it would only lower overall spending by 1%, we'd save $230 million in Medicaid and $860 million overall. This would increase our savings in Medicaid and overall health care. Back to our hypothetical interaction, probably one of the biggest cost drivers in healthcare are providers who order unnecessary scans and pills and consults because they're afraid of getting sued. In this case, even if it's a 1 in a million chance, there's no cost to the provider for ordering a CT scan, but the chances of getting sued are there, so therefore the doctor usually goes ahead and orders it. This is what's known as defensive medicine, and virtually every healthcare provider in the country does it. What usually gets most of the attention is the medical liability system, or the tort system. And in that system, about $250 million is expended every year in verdict settlements and defense costs. But what never gets any attention is the provider's reaction to the whole system, the unnecessary tests and pills and procedures that are ordered, the fear factor that results in $4 billion to $27 billion a year in Ohio in unnecessary spending. Traditional tort reform does not affect defensive medicine, as you can see from this survey. The only way to lower defensive medicine is to have a situation where a provider cannot be personally sued. You see this with Department of Defense physicians because they treat active duty military who cannot sue, and also in most foreign countries who report no incidents of defensive medicine because they cannot be sued. Accordingly, this bill sets up a new system for patient compensation that doesn't involve directly suing physicians, as well as a way to lower preventable medical errors. In our current system, many patients can't find a lawyer to represent them unless they have the right type of injury. Even if they do, their lawsuit could take months or years, and at the end of the day, many of them receive no compensation at all. So the new medical injury compensation system would make it much easier for patients to get compensation, and for that compensation to be awarded quickly and easily compared to the current system. The eventual appeals process can still take them to the courts, but the issue is whether they should be compensated or not. There's never a direct lawsuit against the medical provider. Our current system also does a very poor job of holding providers accountable, because though they can get sued many, many times, they still are able to continue to practice medicine. Instead, the bill creates a healthcare oversight board where any complaint that goes through the injury compensation system would go to the oversight board, so that if they see a doctor is incompetent and needs further training, or is so incompetent that they shouldn't practice, they can remove their license to practice medicine. Also, one of the problems we have in our current system is nobody ever wants to report a mistake or a near mistake because of the fear of getting sued. And the new system, they won't have that fear, and that way we can create a database of errors, which most of them are preventable errors. Actually, they're process errors that can be corrected if we only knew enough about what goes wrong. So we can significantly lower the incidence of medical errors and have better accountability over providers, which would definitely increase overall patient care. With just a 10% reduction in defensive medicine, we can save $2.6 billion in Medicaid and $8.3 billion overall, as well as improve patient health through less unnecessary testing, which can bring extra radiation exposure and false positives, as well as less over-medication and fewer preventable medical errors. This reform would result in significant Medicaid savings and overall healthcare savings, as well as improved patient health. This brings us to the next reform in the bill, which will lower the number of unnecessary emergency department visits. The problem is that emergency departments see many patients who could be seen in a primary or urgent care setting, or some patients who do not require emergency care at all. The problem with that is every patient that comes in costs almost 10 times the amount that your average primary care patient would cost. The problem is emergency departments have to see everybody who comes to see them, regardless of whether they are true emergencies or whether they're better served at a primary care clinic or whether if they require no care at all. The reform in the bill, based on successful practices in several areas of the state, rely on an intake nurse who everybody would report to who comes to an emergency department and would take down the symptoms of the patient. If the patient's reporting symptoms that aren't an emergency, then the intake nurse who will maintain custody of the patient will simply have them go to an adjacent urgent care. And in the event that it actually is an emergency, the urgent care would be able to direct them back to the emergency department. But in this way, we're having patients go to the right setting for the right level of care that they need. The savings that could result from proper care in an emergency department, even if we just have 10% of the unnecessary visits be directed into the right spot, will result in significant savings both in Medicaid and overall. Continuing with our ongoing tally, we see additional savings in both Medicaid and overall. The next reform in the bill aims to tackle the expense of prescription medications as well as expensive medical equipment such as CT and MRI scanners. Prescription medication alone is 12% of our overall healthcare costs, and we in the United States pay 120% more than every other major country in the world for equivalent drugs. The bill implements a purchasing pool system so that all of the medication and medical equipment that's purchased in Ohio goes through one centralized purchasing site so that we can marshal our purchasing power when we negotiate with pharmaceutical companies and medical device companies. Other states that have pooled their purchasing power have achieved significant savings both in Medicaid and overall. And adding those savings to our overall tally, we are up to $3.7 billion for Medicaid and almost $11 billion overall. The next reform deals with incentivizing actual healthcare outcomes for both hospitals, Medicaid managed care companies, and nursing homes. Too often, healthcare providers are incentivized by having perceived quality, by how nice their facilities are, because they're incentivized through how many patients come to their facility. There is a tool called value-based purchasing where you hold back some of the reimbursement, in this case for Medicaid, and then have every provider compete on objective measures so that they're constantly striving to have people be healthier. So for example, survivability after a heart attack for a hospital is one objective measure that's part of the bill. If you incentivize the objective health outcomes with money, we should see much better overall care and constant competition, which is also important among healthcare providers. So we will add those better health outcomes to our ongoing list. And now move to our next reform, which is ongoing competition from hospitals and Medicaid managed care on cost. The problem we have is that Medicaid managed care companies are compensated based on the number of patients they have times a per patient cost that's based on whatever actual cost they can justify. So it's a lot like a defense contractor, but there's no incentive for the Medicaid managed care company to try to make their costs lower. And in fact, there's probably a disincentive because when they do, then it's going to be harder for them to argue for a higher cost the next year with the state. So what I have in the bill is an incentive if they do beat medical inflation and it's lower on a Medicaid inflation rate, then they get a 20% bonus for any amount below that Medicaid inflation rate. So you can see on the chart that in some years they would get the bonus for having their costs be lower, go up by a lower percentage than overall Medicaid inflation costs for the same population. But on the other hand, if they do worse than actually the Midwest average is what we have in the bill, then they lose their contract, and then it's a rebid situation similar to the one that we had a year ago. So there's an incentive for them to always try to beat the Midwestern Medicaid inflation rate. Another incentive is hospital networks would like to get into the game and participate in Medicaid managed care. So if hospital networks can offer a 10% lower per person rate than the Medicaid managed care companies, then they will be allowed to come into the market and participate, which will give an ongoing incentive for Medicaid managed care companies to keep their costs as low as possible. Savings for this reform are calculated by assuming that Medicaid managed care companies can beat Midwestern Medicaid inflation by 3% a year and then receive 20% of the resulting savings. That would save us about $250 million a year overall for Medicaid. So we add those savings, and now we're getting close to $4 billion in overall Medicaid spending per year. Now moving to the next reform and overall Medicaid spending, this has to do with reimbursement for the same exact procedure based on whether a provider is either owned by a hospital or independent. I was very surprised to learn that once a hospital buys an independent practice, the reimbursement rates go up significantly, sometimes 3 or 4 times the amount, even though it's the same office, the same test, same patient. But as soon as a hospital owns the practice, then the reimbursements are significantly higher, which really explains why hospitals are out there buying so many independent practices up. The bill limits the difference in reimbursement for exactly the same medical care for whether something is owned by a hospital or whether it's independently owned, and just a rough guess would be that we could save at least $10 million by implementing such a reform. Adding the relatively lower amount of savings to our overall total because of rounding brings us to potentially $4 billion a year in Medicaid savings. This now brings us to our next reform, which is to help small businesses provide health care for their employees. The bill utilizes an existing area of the law called Multiple Employer Welfare Arrangements, or MIWAs, and helps MIWAs get set up by trade organizations so that small businesses can pool their risk and purchase insurance by themselves or self-insure. When they do that, they're able to save money many times and then therefore provide health care coverage for their employees. This brings me to the final part of the bill, which is the amount of savings that we achieve below current spending levels for Medicaid are then put into pools, which are used to treat the groups that you see in the slide. So the bill specifies that all savings, both its federal and state money, below current spending levels, which we anticipate would happen in 2016 if the bill were to pass, would then be applied to pools, which the federal government has allowed in the past other states to create, which is a way that you can take federal and state dollars that are saved and use it to treat additional populations or augment already covered populations. So in our example, if we have in 2017 savings of $4 billion, $3.1 billion of those dollars would be below the 2016 levels and therefore be applied to the pools to treat those populations. Now, even if we just achieve a flat level of spending year over year for a long period of time, it would be a historic accomplishment. But the bill, by looking at some conservative estimates, should save a significant amount of money so that could then be used to treat these populations. And the bill, again, has pools that are created for the groups that you see on the screen here. We did look at childless adults and look at only 50 to 100% of poverty for the childless adults for two reasons. One, we want to incentivize people to get to a certain level, $6,100 a year in income, so that they will qualify for Medicaid to provide an incentive to work, which is what we ultimately obviously want for everybody, and then take the 0 to 50% of that population and have hospitals treat them, but use the DISH payments, which used to be how hospitals treated the uninsured, but fund the hospitals up to the pre-Affordable Care Act levels, where they used to have to treat a lot more patients with their funding at pre-ACA levels. Now they don't have to treat 0 to 50% of childless adults. That should be a sufficient amount of funding for them to treat that population. So we wanted to make sure that everybody was covered with savings if savings happen. But this is, again, a group of pools that are created in the bill, but I'm open to suggestions. And that concludes the explanation for the healthcare reform bill. I know that was a lot of information. Please contact me if you have any questions, and I hope that you'll support the bill. Thank you very much.